Now the second session is about pediatric topics. I'm Dr. Chuah from the PICU here. So today, I'm going to introduce Dr. Claudia, who is our doctor in PICU, has a great interest in ultrasounds in related to the pediatric critical care. So let's welcome Dr. Claudia sharing these insightful topics with all of us.
Hi, good morning, everyone. Thank you, Dr. Chua, for the introduction. My name is Claudia. I'm a PICU trainee currently based in our center. So before I start, I will have you take a look at this picture. This is a stethoscope on the left, where we are very familiar with, something that we use on a daily basis, and an ultrasound on the right. So having to work in pediatric critical care, always facing a deteriorating child in an ICU setting, I think that having to hear and having to see a situation, the seeing part is even more important. And so today I'll be sharing about how focused ultrasound is changing the way that we assess critically ill babies or children in the ICU. This is the outline of my presentation. I'm going to go on with 4 case discussions and then a little bit of the evidence and then some take-home messages. So I have a disclaimer to make. I'm not here to replace the radiologist, but rather to share just a little bit of experience of how a focused ultrasound can change some of the decision-making at the bedside in the critical care setting. So I'll start off with case number 1. This is a 3-year, 3-month-old girl who presented with cough and fever to the private hospital emergency department in respiratory distress. Then she required NIV support, was admitted to our ICU at around 2 a.m. in the morning. So I'll show you the chest X-ray later. Basically, an opacity over the right side of the lungs that we are not sure whether it's a consolidation mixed with the effusion. She was started on CPAP, a rather high FL2 requirement, and she's also tachycardic. So this is a chest X-ray of this 3-year-old girl. So what would you do? Would you arrange to drain a child because she needs CPAP support, arrange a CT thorax at this hour, or would we wait and see until the morning? So this is when the bedside ultrasound lung comes in useful at the bedside to determine the nature of the opacity. So for further decision making in a child who's sick. So you can see the video clips that I shared currently. So this is you can see that I labeled the lung empyema, which is like a fibrin-filled content in the pleura with a background of a collapsed lung. Okay, that is very hyperechoic. So actually, this signifies quite a large lung empyema and lung atelectasis, which could suggest of a necrotizing pneumonia. So this is the pleural drainage that we make after careful arrangements. That you can see these are pus and necrotic tissue from the pleural drainage. And then this is her with making a recovery. You can see that with careful arrangement and decision making, she can make a good recovery later on. So lung ultrasound actually has very good sensitivity and specificity in diagnosing childhood pneumonia. It could, in papers that we mentioned that it can offer as an alternative to the chest X-ray. And specifically high sensitivity and specificity as for fluid for pulmonary fluid overload picture as compared to the chest X-ray, and it is not only a good method to assess the lung parenchyma, but it's also a good method to confirm the airway and also endotracheal tube depth in children. I'll quickly move on to case number 2, which is a case that is a 7-year-old with a weight of 25 kg with a dilemma of using more fluids or starting a vasoactive agent. So he presented to ED with increasing lethargy, rapid breathing, and also fever. On presentation, he was tachycardic. He's hypotensive for age, and he was already started. He was given a fluid bolus normal saline, 10 ml per kg. However, his situation did not improve. He progressively became more tachycardic and hypotensive following that. So at this point of time, you'll be wondering in the emergency department, for my fellow pediatric colleague, will be thinking, should we give more fluids? Should we start some inotropic support? What are we dealing with at this point of time? So when we put on the echo probe, a very handy machine that we use on a daily basis, we can see that on these echo clips, we can see that actually these I hope you can see my arrow. This is the left ventricle. You can see that it's rather dilated and the contractility is actually impaired in this child. So then it gives us an idea that actually the heart functions is actually impaired. And by doing further measurements like the velocity time integral called as the VTI, whereby we actually tilt the probe upwards to look at to look at the LV outflow tract, to look at the LVOT, to look at the VTI by measuring the waveform reflection. And actually, when we measure for this child, it actually showed that there's a significant reduction to 9.46 cm, which is less than 10 cm. So we know that we got to be very careful with our fluid usage. And yes, at this point of time, starting some adrenaline would be helpful in improving the inotropy and the chronotropy of the heart. But is that all? So I will also talk to you a little about this diastolic feeling especially to my pediatric colleague and to the critical care colleagues, that not only we are looking at systolic dysfunction in heart failure, we are also looking at the diastolic feeling. So diastolic feeling is the filling of the ventricles, where in this schematic diagram, we know that in the diastolic filling, the 2/3 of contribution is by a passive filling from the atrium, and only 1/3 is by the active contraction of the atrium. So we need a good relaxation of the ventricle to get a good filling rather than a good atrial contractility. Okay, so when we measure the diastolic dysfunction of this child, we can see that the first peak and the second peak refers to two different things. So the first peak refers to what I mentioned earlier, which is the passive LV filling, which reflects how good and how relaxed this LV and how compliant it is to take in bloods during the diastole phase. Okay. Then the second peak refers to the atrial contraction and how hard this atrium need to contract to pump against pump against this restrictive or not relaxed LV. So in this patient, we can see that actually there is already there is an abnormal LV feeling, which is suggestive of some diastolic dysfunction. So this is on the top, which is just a wave flow of how we look at the diastolic dysfunction. If you look at the pattern recognition of this pattern, we can see that actually it falls into this pattern. And I'm just putting up this lower part of it, which is a more advanced measurement, which is called the tissue Doppler index, the TDI, to look at not only the flow, but also look at the movements of the mitral annulus to look at to grade diastolic dysfunction. So hence in this child, he has got a LV systolic dysfunction, and he's got also a diastolic dysfunction. So LV, like I said earlier, it is weak, it is restrictive, and it is not able to relax. And in this child, actually, he has got a myocarditis, and hence the pressure builds up in the LV, and then it transmits backwards and causing this pseudo-normal high E peak. So in this scenario, not only using adrenaline will help us, but the use of murinon or adding on the murinon at the early phase will also improve the LV feeling but with the lusitropic effect while treating the cause of myocarditis in this child. Next is a 9-year-old girl. She came in with reduced consciousness and reported by mom not waking up for the sahur during the recent fasting month. She presented to the ED and was intubated because of low GCS, and the CT brain confirmed that she actually has got a parietal intracranial bleed. And she then underwent, she was sent here, and then she underwent a craniotomy, and then subsequently was sent to us in the ICU for cerebral protection. So how do we we know that in cerebral protection, we need to maintain a good mean arterial pressure. But what is good? What is adequate? Having to do cerebral protection in a scenario, I'm talking about a scenario without an invasive ICP bulb monitor. What is adequate? So we know that in the formula, the cerebral perfusion pressure is equivalent to the mean arterial pressure minus of the ICP. So hence the use of transcranial Doppler in this scenario is very useful. I put out an example of a few intracranial pressure. If you look at the second row, which is the yellow color numbers, if I have got a similar systemic BP for all these various kinds of intracranial pressure, and when we minus off, we know that this mean arterial pressure minus of the ICP is essentially what we get in the cerebral perfusion. As the intracranial pressure increases, the cerebral perfusion pressure pattern actually reduces. So it actually defeats the purpose of our cerebral protection measures. So it is to this end, it is actually negative pressure, and it is almost like an arrested cerebral vascular circulation. Hence, in this child, when we measure her transcranial Doppler, we can actually notice that actually this pattern showed that is a high resistance in the cerebral perfusions while on this MAP. Hence, we know that it gives us a real-time guidance of how much of inotropic support we need to titrate up to achieve a good MAP for a good cerebral perfusion monitoring for good cerebral protection. So in evidence, it's actually mentioned also that transcranial Doppler is also useful in detecting raised intracranial pressure in those with early traumatic brain injury, and it correlates very well with our invasive ICP monitoring. And there are several measures like the end diastolic velocity of less than 25. It shows that it's a poor prognosis, or a PI, a pulse vitality index of more than 1.31 is actually showed that it's a poor prognosis. So hence, I will also share with you this case that we recently encountered in our ICU, which is a 4-month-old child who has brought in with no signs of life. And actually following a prolonged resuscitation, he had a return of spontaneous circulation. And he was sent for a CT brain and actually showed that he has got multiple intracranial bleed with a generalized cerebral edema. So if I put up this transcranial Doppler waveform, and if I may share with you that this one is actually a very bad waveform, whereby this is almost like a cerebral circulatory arrest, whereby this child is almost what do you call this? It's almost brain dead. So it gives us a clue that at this point of time, we know that we need to go very aggressive with our cerebral protection measures. So subsequently, this child showed a complete brainstem dysfunction, and the withdrawal of life-sustaining treatment was subsequently made. So transcranial Doppler is not only useful to detect, to help us in our real-time measurement of our intracranial pressure. It is also an ancillary tool to be used for pediatric brain death assessment, especially places that has resource limited with imaging. Last but not least, I will share a case. This is a case that I encountered in my training in another center. This is a 6-year-old boy who is 19 kg. He has got underlying interhemispheric subarachnoid cyst with a corpus callosum agenesis. So he actually was treated, presented with a neurogenic pulmonary edema, and then he was intubated. He required a few vasoactive agents. However, on day 2 admission, his right lower limb was noted to be pale, blotchy, and also swollen up to the thigh region. So very quickly, we could perform an ultrasound, a Doppler at this point of time to look for vascular patency due to the suspicion of arterial thrombosis. So we can see that actually, and in this ultrasound image, you can see that actually this branching pattern, branching of the deep arteries. You can see that proximal to it, there is actually no flow seen. Okay, so when we pulse this artery, we can actually appreciate like a biphasic kind of waveform, which give us a clue that there is an the arterial flow is actually impeded. So then not only can we observe that, we can also appreciate the muscle edema on the ultrasound. On the right is actually a normal muscle that can see a good marbling that looks like a piece of meat here. And on the left is actually the patient that you can see that there is this loss of marbling, and there is also a edema of this muscle. And true enough, our suspicion was confirmed with biochemical markers with a CK raised and a raised LDH. So because of the suspicion of catheter-related arterial thrombosis, while considering a surgical thrombectomy in this 6-year-old, but because of his poor cardiac condition and his underlying condition, so decided to give a start the bedside to start at the unfractionated heparin at the bedside and continuous assessment with clinically and also radiologically. And he later went for a CT angiography and confirmed this long segment thrombosis in this child. So this is a full resolution of his I mean, this is not a complete resolution. This was about 2 months after the incidents, and actually showed that there's a gradual resolution of area of the thrombosis, and he made a full recovery after that. So actually there are many case reports, or if I haven't convinced you enough that ultrasound plays an important role in our day-to-day practice, and there have been many case reports on successful limb salvaging or limb salvage during using a serial bedside Doppler assessment for flow restoration. So with this assessment of this Doppler at the bedside, we can actually quickly make a decision of starting of unfractionated heparin or low molecular weight heparin, and also to monitor the reperfusion following catheter-related arterial thrombosis. And in fact, there are high success rate, especially in doing vascular access in pediatric age group, and also in our setting, we do a lot of vascular access insertion using the ultrasound. So my take-home messages today is point of care ultrasound. It answers many specific clinical questions in the critical care that may change our bedside management. It is not only quick, it is repeatable, it is very dynamic. And then, however, it is never a replacement to our formal imaging. I will actually urge us that this is a good skill to acquire with training. And in pediatric critical care, what we see guides actually what we do. So what we do change a child's life, and that is what we want to achieve in our day-to-day practice. So with that, I thank you.
Thank you very much, Dr. Claudia, for such an insightful talk. So then, let me see whether there's any questions from the floor. Yeah. Okay. I think till now we don't have any questions from the floor. Just to share that at this moment, ultrasound service gaining more and more positions and become important for intensivists in helping us in managing patients, especially beside from it's not completely kind of diagnosing, but help us to monitoring the care that we have given. So it helped us quite a lot on the decisions makings. So okay, we have another questions from yeah, everybody is very interested how Claudia acquired the competencies of the ultrasounds that she has now. So how many years it takes to learn all this?
I have to say that some of the images are not done by me, but I have I think it takes a practice on our day-to-day as to how every patient that we see or things that we want to confirm, things that we want to hear, or what we hear may not tally with what we see on the X-ray and that sort. So I think hence the ultrasound comes into practice. So with practice uh it can be done. Not many years, probably less than a year, probably a year.
So, for information, actually for pediatrics intensive care trainings, all of us have to go through, say, the ultrasounds trainings, whether that is kind of clinical bedside trainings, or formally we can join some course which give us some basics informations. And though Claudia has a special interest in it, so though Claudia specifically spent 2 months with our seafood, ultrasound seafood in Sarawak with Dr. Chuah. So she gained quite a lot in terms of the knowledge and the skill um, uh, in these fields after the 2 months. It's really it's a practice that makes perfect.
Yep. Yeah, agree.
60 attempts or any skill. Okay, so I think we don't have any questions after this curiosity about the competencies of ultrasounds. So I think if we don't have any questions from the floor, I think we'll formally close the sessions. Thank you very much, Claudia, for sharing this session with all of us. Thank you very much.
Bye. Thank you, Dr. Chua. Thank you, everyone.